Hi, everyone, and welcome to this RSNA 3D Printing Special Interest Group webinar on the RSNA-ACR 3D Printing Registry. I'm Dr. Nicole Wake, the Director of 3D Imaging in the Department of Radiology at Montefiore Medical Center and the current SIG Treasurer. I will be moderating today's session. Before we get started, for those of you who may not know, the RSNA is the Radiological Society of North America. The mission of the RSNA is to promote excellence in patient care and healthcare delivery through education and technologic innovations. RSNA has over 52,000 members from over 153 countries around the globe. Within RSNA, we have a 3D printed special interest group, which was founded by Dr. Frank Rubicki in 2016 after 3 successful years of educational and hands-on sessions at our annual conference. And the SIG's mission is to promote the highest quality 3D printing applied to medicine via education, collaboration, and research. Our focus is to maintain a prominent role for radiologists in this diverse and growing specialty. We also seek to provide physicians and allied health scientists with optimized education and research. Please visit the RSNA webpage if you're not already a member and would like to become one. The SIG, now in its 5th year, has been making significant contributions to the field of medical 3D printing, and these efforts include publications on 3D printing guidelines and appropriateness for clinical scenarios, such as this paper on the left-hand side, which was published in 2018, and this one on the right-hand side, which was just published this week. We also have had joint meetings such as this one with the FDA in 2017 and are interested in maintaining the safety and efficacy of 3D printing in medicine. We also have efforts to support the CPT Category III codes and create the registry, which is the focus of our webinar today. And we have active work groups on quality assurance, regulatory considerations, and education. Today's webinar on the RSNA-ACR 3D Printing Registry will present the whys and hows of registry participation and why participation will help to support future Category I CPT codes. The registration process will be reviewed along with issues related to the IRB, and then details of the registry data dictionary will be presented and several examples will be shown. We'll conclude with a question and answer session at the end. We're extremely grateful for our speakers who've taken the time out of their busy schedules to educate us on the registry. And here with me today, I have Michael Simanowith, Priya Sharma, they're both from the ACR, and Dr. Ken Wang from the VA in Baltimore. Dr. Michael Simanowith from the ACR is the Director of Registries. He joined the ACR in February of 2019 and leads an analyst and support team primarily responsible for registry definition, data collection, metrics reporting, and participant issue resolution for the 6 quality improvement registries and associated pilot programs, including 3D printing under the NRDR portfolio. And prior to the ACR, Michael was the Director of Registry Science at the American College of Cardiology for 9 years, where he oversaw the scientific development, implementation, and public reporting for a suite of 10 cardiovascular QI registries. Priya Sharma is also from the American College of Radiology. She's an Associate Quality and Safety Operations Specialist. She has been with the ACR for 13 years. She's a senior member of Quality and Safety Support Team, responsible for enrollment, billing, and operational issue resolution for ACR's accreditation and registries programs, including the 3D printing pilot. Finally, we have Dr. Ken Wang, and he's the MRI section chief at the Baltimore VA Medical Center and an adjunct assistant professor at the University of Maryland School of Medicine. He received his PhD in electrical engineering from Stanford University and his MD from UCSF. He completed his radiology residency at MSK, fellowship at Johns Hopkins Hospital. Ken is a member of the RSNA Radiology Informatics Committee, where he serves as the chair of the RADLEG Steering Committee, and he is the liaison to the RSNA 3D Printing SIG. So now I'm going to hand it off to our first speaker, Michael, who will be leading us off. Thank you for joining us.
Thanks, Dr. Wake. Sorry, let me
share
my screen.
Yeah.
Yes. All right, is that coming through now?
Yes. Thanks, Michael.
Okay, great. Awesome, thank you. So thanks for the introduction, and we're really excited about launching this new partnership with RSNA. I'm, as Dr. Wick mentioned, Mike Simanowicz. I'm Director of Registries at ACR, and I'll be joined by Priya Sharma, who is on our support team and a lead there. And should you decide to enroll, with probably one of your first points of contact or someone on her team would be during the registration process. Just as also as a background of the NRDR, which is the National Radiology Data Registry, which is the umbrella of quality improvement registries that we run at ACR, and 3D printing will be becoming a member of this. It'll be listed originally as a pilot and not a QI registry. We'll show you how that will display shortly in the upcoming slide. The NRDR, in general, we have over 6,000 facilities and upwards of 170 million exams. The registries span different areas of radiology, be it different procedures, or we also have our general radiology improvement database, one of the first that we launched in 2008, all with the mission of improving quality and advancing treatment in radiology. And we do that primarily with 2 ways: with benchmark reports that sites get either on a quarterly basis, or we also have interactive reports that are more on demand. And that will be something we're starting to look into for the 3D printing, but for now, we're in just the data acquisition phase. And we also do research. So each of the registries has a research arm where data can be requested, and different studies can be done in the effort of improving quality. This is just a quick slide of the coverage of the NRDR. You can see it spans pretty much all states in the U.S., and we also do have some international sites as well, but primarily are domestic. Sorry, having a little, there we go. Now, as for 3D printing, that you can get to the information for the website now. If you go to the acr.org site, under the Practice Management, Quality, and Informatics, there's a selection for our data registries. Under that are all the current data, the QI registries, which are listed first, and then the 3D printing registry. If you select that link, you'll be brought to the information site for the 3D printing registry. Here you can find out how to participate, which Priya will go into this in more detail in the next slide, but there is just the links to how to participate. There also are links for logging into the registry itself once you do enroll, as well as assistance numbers and links to get help if you have problems enrolling, or when we are collecting data, if you do have issues with populating the data or sending us that information. These links and the phone number there are your best support system. And I have this as a slide onto its own at the end. Also here is the data dictionary, which lists all the elements that are going to be collected. And I think Dr. Lang will be going into that in more detail coming up. But just wanted to give you a quick overview of how you can access the information now. The website for actual collection isn't ready yet. I'll talk about that after Priya gives you an overview of the registration. So Priya, I'll hand it over to you.
Hey, thanks. Just the next slide. Okay, so there's different steps when you're registering for NRDR. It's whether you are already a participant in NRDR or if you're brand new to NRDR, and I'll kind of go over both. So if you're brand new to the NRDR, you would first have to complete a corporate account registration, and that's essentially an operational account. We use it to link facilities, for payment, any of the major notices, and things like that. So corporate account will have that information first, and then you add your facilities, which are the locations that are performing any exams. Once you add those, you would also have the option to check off what registries you do want to participate in. So on the right, you'll see descriptions of each of our registries with 3D pilot, or 3D printing, which is the pilot registry, up at the top. You would check that off and proceed through the application. In order to accept your registration, we would need a signed participation agreement and business associate agreement. We do have a one-time NRDR fee of $500, and then you also have an annual fee of $500, and that we have set up as the special rate, and it doesn't matter how many facilities or locations and physicians you have. For all of our other registries, it is a sliding scale, but right now 3D printing is set at that $500 fee. Now, if you already participate in NRDR, for the most part, this is already going to be included in that cost if you are participating in GRID or DIR, which is Dose Index Registry. And so if you're not already a part of NRDR, your corporate administrator would add the 3D printing registry and also add users to the 3D printing registry to set that up. Now, if you're unsure of whether your facility is a part of NRDR or is not, the easiest steps would be to submit a support ticket, and that would be at nrdrsupport.acr.org with the name of your facility and an address so that we can take a look, see what the status of your facility is, if it's already participating in the registry, and if it's not active, how you can take over that account essentially. But we're always willing to help you out and get you started. I will say it looks a little bit cumbersome when you're starting and you're getting to it, but once you're in the system, it moves along pretty quickly. And that's just a really short setup for how to get started in the registry.
Okay, great. Oh, there we go. So thanks, Priya. Once you are enrolled in the registry and logged in, this is a preview of the screens that you will see. I'm not going to go through all of them, but just to give you a coming soon. On the left side is the navigation for across all of the NRDR platform. You may not see, I'm actually in as a super user, so I have a lot of screens that you may not have when you log in, but towards the bottom, you'll see the pilot and research registries with a link to the 3D printing registry. That will then bring you to what's on the right. And here is where you would really do the majority of your navigation through the case form. You see circled there, I'm sorry, it's a little fuzzy, but registering a new case, and then we'll bring you up the full case form to enter all the data for the individual 3D printing case. As I mentioned, this part isn't quite available yet. We're anticipating, we're in the testing phase now and everything's going quite well. So we're anticipating we should be going live end of June is our hope. Now you can enroll. You just won't be able to actually enter cases until that June launch date. Finally, again, here is the support information. We have a staff at ACR of 5-10 folks for various subjects in the support process. We also have if you go to the NRDRsupport.acr.org, there's a searchable knowledge base with a few articles now on the dictionary, the submission mechanism, and we're going to build that out as we roll out more and more functionality. You can also use the email, but the site should be probably your best first step. There's an email and phone number as well that we will support you with any questions that you might have on the process and submission. And that concludes my portion. I'm passing over to Dr. Wang. Yeah. Oh,
Dr. Wang,
sorry.
next. That's okay. Thanks, Priya and Mike.
Yep, great. Let me share my screen here. Okay, I presume that's showing okay?
That looks good, Ken.
Great. And thanks again, Nicole. Thanks, Mike. Thanks, Priya. So I'm going to spend the rest of our time prior to our Q&A session at the end talking about the details of the registry. These are a couple of disclosures that I want to show, and also just to say it, I want to make sure that I state that as an employee of the federal government, what I'm saying today is not reflective of a position of the government. I also want to acknowledge our 4 vendor supporters. These are Formlabs, HP, Materialize, and Stratasys. All 4 of these vendors have provided support to the registry. The registry would not be possible without that support. Okay, so what I'm going to talk about today is the following. I'm going to say a little bit about the what's and the whys of what the registry is. I'm going to say a little bit about the timeline that we've been on with this project. I have a few thoughts about data privacy and IRBs. And then I want to spend most of our time remaining talking about the data dictionary. That is, what is that document really showing us, and how does it work, and how can you use it? Okay, so in terms of the what's and the whys of what the registry is trying to do, what we're really doing is we're trying to collect information all along the kind of the chain of 3D printing for clinical applications. And so that starts with a clinical problem as demonstrated on medical images. It includes consultation with clinicians about those problems, how 3D printed objects can help. It goes through to image segmentation and the construction of printable objects, and then through finally to the printed physical objects themselves. Throughout this talk, I'm going to be showing a few images of my own and some images shared with me graciously by others. Okay, so in collecting that information, really what that allows us to do, or will allow us to do, is to conduct a systematic analysis of clinical 3D printing. And what I mean by that is kind of a systematic way of looking at, well, how frequently is this work being done? How widespread is it? What are the clinical reasons that people are doing clinical 3D printing? What technologies are they using? How complex are their models? How much work does it take? And what is the clinical impact of this work? And the reason that I think particular sites may be interested in participating in the registry are really 2 reasons. One is for institutional quality improvement efforts. So if you're at a site and you know that your work in clinical 3D printing focuses on a particular area, let's say orthopedics, and you're also aware that others at other institutions are doing 3D printing for a variety of other purposes, but that awareness may be somewhat ill-defined. The registry will really provide information to you as a site to say, well, here's your case volume in a particular clinical area, but when you compare that to the rest of the registry, you may see that there's really a lot of activity, a lot of case volume that's happening in, say, urology or in neurosurgery. And what that would provide you with as an institution is the opportunity to expand your clinical practice, to improve the quality of care in some other areas where you may not currently be focusing, and to do so in a data-driven way so that you can know that, I see that the registry shows that really the #1 area of clinical application is this area. The second reason why I think sites are interested in participating in the registry is for the reason of reimbursement. And we all know that to make these models is kind of a labor of love, and it takes a ton of work. We enjoy doing it, and really for this to be a sustainable, long-term technology for clinical care, reimbursement is an important part of that. And the data collected by the registry, the systematic analyses that it will enable, will be an important part of the support for a future Category I CPT code. All right, so with that, I want to say just a little bit about the timeline that we've been on with the registry project. And so going back to July of 2019, July 1st of last year was the date that Category III CPT codes, Nicole mentioned this briefly, that those CPT codes went live. Shortly thereafter, RSNA and ACR signed an agreement to collaborate on this registry project. In August, then, our set of 4 corporate sponsors was announced. Back in October, the registry actually opened for registration, that is, facilities could start to enroll as participants. This past February, the data dictionary document was released, And then now, as Mike said a few moments ago, we're now tracking towards sometime late this month for opening of the registry for data submission. And I do want to note briefly here that when that happens, sites and users will be able to submit retroactive cases that have already occurred. One date that we're interested in is July 1st, 2019, because that was the date that the Category III CPT codes went live. So cases back to that date would be of interest to the registry. On the other hand, we recognize that some institutions have already been tracking data in anticipation of this retroactive submission. Others may not be, in which case it may be hard to know the details of models that you made sometime in the past. The quality of the data submitted is important to us, so those are just two things for us to balance. All right. Next, I do have a few thoughts about data privacy and IRBs and how that relates and may affect registry participation. All right, so I would start by saying that the registry has been designed to avoid collecting any PHI in order to make it easier for institutions to register as participants. So the intent is to collect no PHI. I'll have more to say about that in just a second. I also want to make you aware of an organization called ADVERA. ADVERA is an IRB that works with ACR and serves as the central IRB for the NRDR registries. ADVERA has reviewed the 3D printing registry and has deemed it to be exempt from IRB oversight. And we have that as a formal document. Even so, many institutions will require their own local IRB review prior to registering for the registry. I imagine that that includes most large academic institutions. On the other hand, it's not everybody, and I am aware that there are certainly participants in other NRDR registries that do not require their own local IRB, and that would certainly include practices that don't have their own local IRB. So, so this is a site-dependent issue. But if you do require a local IRB, there are some documents that I would like you to be aware of. So these are 3 documents that I'm showing here. On the left-hand side of the screen is a description of the registry, its objectives, and this is kind of a protocol describing the operation of the registry. That's the document that was reviewed by ADVERA. This document in the middle is the decision letter from ADVERA indicating that the 3D printing registry is exempt from IRB oversight. And then your own local IRB may be interested in reviewing the details contained in the data dictionary, which is shown on the right-hand side of the screen. These 2 documents on the left are available on the SIG community website in the library section. And this document on the right is available online. I posted a link into the chat box. Hopefully you can see it there. If it's scrolled off, I'm going to ask one of my colleagues to paste it back in there. Okay, a couple more thoughts on the avoidance of PHI. There are really 2 sides to this issue. The way that the registry has been designed, the data fields do not ask for any information that would constitute PHI. So you'll notice that we collect age information, but we do not collect any date information, nor any institutional names, certainly not any patient names or provider names. Even with age, you'll notice that we collect only age in years. While for some pediatric populations it would be useful to know about age in months or even weeks, we only collect age in years to comply with the idea of no PHI. You'll also see that for elderly patients 90 years or older, that we don't collect a specific age in years, but simply the descriptor greater than or equal to 90 years. All right, so the registry won't ask you for any PHI. The other side to this issue is that we really are going to we ask users and we're going to rely on users to make sure they don't enter any PHI in any free text entry fields. So there are some places in the data dictionary where free text is required for people to tell us more about what they did. In those fields, even though it's possible that you could enter a date or a name or an institution or something like that, we ask you not to do that. Okay, so again, this is the data dictionary document. I think there are a couple of different links to get to it from. This is the one that I pasted in the chat box. And if you haven't seen it already, I'd encourage you to click on this now and pull it up, and you can follow along as we're talking about it. All right, so before I get into the details of what this document shows, I want to kind of give you a sense of its structure and go over a little bit of the anatomy of some of the pages in this document. All right, so here on the table of contents, you'll see that there are 9 sections with these different section headings. And then at the end of the document, there are a number of appendices. So the 9 sections talk about the specific data fields that are being collected. The appendices give the terminology that we've defined for responding to those data fields. And I'll illustrate what I mean by that. Just to mention them briefly, so these sections, Section 1 collects some high-level case information. Section 2 collects information about the imaging exams that are used and the clinical indications for the 3D printing. Here I would make the distinction. We're talking about indications for 3D printing, not indications for imaging. Section 3 talks about the digital modeling, that segmentation and CAD work that you might do. Section 4 talks about the printers. Section 5, the 3D printed models themselves. Section 6 refers to the intervention or surgery for which the object was created, if applicable. So if you're making something for a surgical planning purpose, this is asking about that surgery. Section 7 is an important section asking about the amount of effort or work that went into the creation of this object. Section 8 is a series of subjective Likert style questions asking clinical end users of the 3D printed object what they thought of it. And then Section 9 is a set of quantitative outcome measures related to the use of the object. Okay, now I mentioned anatomy of the data dictionary pages. So this is what a typical page looks like. Here we're in Section 2. Each section comes with its own section header, which is shown in red here. And that header is just a description of what that section is really talking about. It gives you an overview of those fields. That header is followed then by a number of discrete blocks that are called field definitions here. Let's look at that a little bit more closely. So here we have the field definition for field 201. Each field definition has these different pieces to it. So it has a number, again, 201 in this case, and it has a name, patient age at exam. There's a description of what this field is about, then an indicator of whether this field is optional or required, and then finally a statement about the values that are allowed in the response to this field. Okay, so throughout the document you'll see a number of different fields that kind of increment in their field number, each with their own unique descriptions. All right, here I'd like to make note of the idea of multiplicity. And what I mean by this is that in some cases, certain fields or even collections of fields can be specified more than once. So you may have multiplicity of fields. And that this multiplicity can sometimes be nested. And I'm going to show you what I mean by this. But I anticipate that this may be a source of some confusion for users. And so I just want to state up front that there is this idea of multiplicity, the possibility of nesting. I am going to illustrate this. This is not a complicated concept, but I think potentially confusing. In order to understand this, I'd say you can look at the section headers or preambles. And some examples of when we want multiplicity is when we're talking about, for example, imaging exams. We used multiple scans to create this model, and we need a way to talk about each of those scans, et cetera. And again, I'll show you what I mean by that. All right, so what I'd like to do next is go through these sections and talk about specific fields in some detail, focusing on some areas more than others. Again, Section 1 really just collects some high-level case identifying information. One field that I do want to pause on for just a moment is field 103, the institution case identifier. What this is a number that you, the user, will assign to the case that will kind of be a marker for that case. But in the vein of no PHI, it's very important that this identifier not be, for example, a medical record number or an accession number or any number like that. It shouldn't even be an encrypted version of any of those numbers because even that is considered to be PHI. So my own plan in my institution is to assign just a running counter to cases. So my first case will be like case 1, and then the second case will be case 2, maybe with some zeros in front. And then it's on each site or each participating institution to maintain its own internal mapping of, oh, case 1 is really refers to this patient, case 2 refers to this other patient. And so you have that mapping. The registry won't have that mapping and doesn't want to know that information. All right, so enough about that. Let's go into Section 2. Section 2 is asking about the imaging exams used to create a model and also the clinical indications for doing the 3D printing. This will be fairly intuitive for most, I think. So fields 201 through 209 describe a single imaging exam. You can have multiplicity of these exams up to a total of 5 imaging exams. And so here I'm just drawing a table with fields 201 through 209 across the top, and up to 5 rows populating a table like this. So for example, if you're making a model of an abdominal aortic aneurysm and you used a CTA to do so, here's how you could describe a CT of the abdomen and pelvis. We're giving the patient's age. In field 203, we're giving the modality CT. In field 205, we're saying that this is a scan of the abdomen and pelvis. And this is an example of what I meant earlier by nested multiplicity. That is to say, the imaging exams, the lines of this table can be multiple, but inside each line there can be multiple values of a given field. So field 205 would have the value abdomen and the value pelvis because this is a CT of the abdomen and pelvis. The scan was done with IV contrast and without PO contrast. Here's another example, a 55-year-old woman. By the way, these are all fabricated clinical scenarios. So a woman for ovarian tumor resection, 2 different imaging exams used to create 3D printed model. In this case, a CT and then an MRI of the pelvis focusing on the ovary. Just a third example showing again that these exams can be multiple. Finally, I'll show this one. This is a 90-year-old man for a liver mass ablation model created based on CT of the abdomen and pelvis. Given the age, I'm just illustrating here that age field 201 was not specified, and instead in field 202, the code number 1 was given. If you look in the data dictionary for field 202, you'll see that code number 1 means age greater than or equal to 90 years. Okay, so that's imaging exams. I will say that in describing imaging exams, we've been referring to anatomy, and the way that the registry talks about anatomic things is described in Appendix A. Appendix A describes kind of a system of anatomic terms divided into regions, subregions, and structures. For the purposes of imaging exams, mostly what we're interested in is just the region, so a CT of the head or a CT of the chest, etc. We're going to reuse this table later when we talk about anatomic segmented parts, and there the subregions and structures will become more relevant. I want to emphasize here, though, that for imaging exams, it's mostly the regions that are most relevant. Section 2 also collects information about clinical indications, and these clinical indications are based in part on the work of the SIG appropriateness committees and all of the work that they've done, so thank you to them. One point I would make here is that, well, 2 points. In some cases, the specific clinical diagnosis that applies to a certain case will be more specific than the registry is able or interested in capturing. So here a patient has non-small cell lung cancer. What I've done in this table is I've specified that we're talking about the chest and that the diagnosis is lung cancer. We're not capturing the histology of this diagnosis. And the reason for that is really that in the registry, we're trying to balance specificity with simplicity. And if we really wanted to capture lots of histologic detail, that would make the terminology much, much larger. Just another example, this one with multiple indications. Here I'll note that one of the indications should be marked as the primary indication. Okay, and again, these terms come in part from Appendix B and rely in part on the work of the appropriateness committees. Okay, Section 3. This is a big section of the data dictionary that collects information about the type and the purpose of the 3D printed object, information about the software that you used, and also about the specific parts that are segmented or created. I'm going to focus on the first and the last one of these parts here. All right, so first the type and the purpose of the object. And you'll notice I'm saying object, I may be saying model sometimes, but a fair amount of thought has gone into what types of 3D printed objects should be captured by the registry and how it should describe them. I'm going to refer you to these pages in the data dictionary. This is the preamble for Section 3 and the descriptions for fields 301, 302, and 304. This talks in detail about what I'm going to show you on the next slide. And that is to say that the registry is trying to capture information about two types of objects, anatomic models or anatomic guides. What this doesn't include is it doesn't include 3D printed implants. The registry is not currently receiving or not currently designed to receive information about implants. It also does not include external prostheses. And certainly there's a lot of work done in both of those areas, but these are the two types of objects that we're focusing on here. Anatomic models, there's a series of different purposes of anatomic models that are defined in that descriptive text. And there's also a series of types of anatomic guides that are described. And again, I encourage you to read those details. All right, so then another part, this is that last part of Section 3, is the anatomic parts of the printed object. There could be parts of an anatomic model, or there could be parts of an anatomic guide. So first, for the parts of an anatomic model. Anatomic models, what we've decided is that these models can have up to 20 parts. Again, we're using the terms described in Appendix A to describe these parts. And a goal with Appendix A was to allow people to talk about lots of different kinds of anatomic parts while using a relatively small number of words. This is that Appendix A again. And so just to show you a couple of things. So this is a simple model of the scapula. It's a one-part model. This is an anatomic model. It has a single part, which is a single line in this table for these fields, 313, 314, 315, 316, 319, and 320. I'm describing this with the region upper extremity, subregion shoulder, structure bone. I haven't actually named scapula here, but I've come down on scapula by kind of narrowing down the anatomic area, and I've supplied a laterality of right. All right, here's an image from Dr. Pete Leokouris, who's done a ton of amazing things at Walter Reed. This is a model of an intracranial tumor. And so this would be a three-part anatomic model with these three lines in this table. Region head structure skull, that's the bony portion. Region head structure tumor, that's the mass. Region head structure artery, that's the arterial tree shown. All right, here's a beautiful model of a renal tumor from Dr. Wake, and this is a model with 5 parts. So this is the kidney, the renal mass, the renal artery, the renal vein, and the collecting system. And so correspondingly, there are 5 lines in this table and described in this way. All right, so those were anatomic models. And again, the other kind of object that we can receive information about is anatomic guides. Guide parts are described in a different way. We've based this in part from guidance we received from folks at the Mayo Clinic and others who are active in producing anatomic guides. So there's a more limited fixed set of terms that can be used to describe guide parts. However, if there's a part that you need to specify which is not present, there is the option to enter guide part other with free text. Okay, and so some examples of this, these images are courtesy of Dr. David Hirsch by way of Andy Christensen, thank you. This is illustrating mandibular reconstruction with the fibula. And so these guides consist of 2 parts, the mandibular guide and the fibular guide specified like this. This next example is from Amy Alexander at the Mayo Clinic. And every time I see images like this that illustrates the work that Amy and Jay Morris and Jane Matsumoto and others are doing at Mayo Clinic, I'm amazed by what they're doing. And so the way we would talk about this guide in the context of the registry is we would see that there are two parts to this guide. They're both maxillary guides. And as such, they can be differentiated from one another with this free text comment. Here I've marked one as the more lateral guide part, the other is the more medial guide part. Okay, so that was how we talk about parts of the models and guides. I do want to make sure we have enough time for questions and answers, so I'll not spend too much time on the remainder of this. Section 4, again, talks about printers. I do want to mention again here that, well, I don't know if I said this earlier, but the objective is to allow participants to really define a library of printers that you maintain. You wouldn't be working with that list of printers on a per case basis, but you would maybe do this once at the time that you register for the registry, or modify this list each time that you install a new printer or decommission an old one. But then each time that you go through a case, you would simply reference this library by virtue of some name that you've assigned to particular machines. So here are 3 machines that we have at the University of Maryland. This would constitute part of our printer library, and for each machine, I've assigned a label here. Now when I actually go to print an object, then in discussing and describing how I conducted that printing, I can refer back to that printer library by virtue of that local name I've assigned. All right, so Section 5 now collects that information about the 3D printed object. And something to note here is that we have allowed for the fact that people may sometimes print different subsets of the segmented parts that they've created for different purposes. You might choose one set of parts for one user and a different subset of parts for another user. The registry allows for up to 5 of these subsets of parts, each one constituting a 3D printed object. Here I am referring back to that renal model from Nicole. The anatomic parts list is a list of all the parts that we described. These are those 5 parts for that renal mass model. There's information about the scale, the printer, information about the amount of material, the material properties, print time, and the number of copies. Section 6, I mentioned this briefly. I don't think it needs too much more discussion. Section 7, I do want to take a minute on. Again, this section focuses on the amount of effort that went into this episode of clinical 3D printing. We've defined 2 classes of staff members, clinicians and non-clinicians. And then we've also defined 4 types of work that are involved in producing a model. Consultation is any discussion you have with a referring clinician about the reasons for making a model, the specific diagnostic information that's desired in the model, the function of the model, that kind of thing. Segmentation work, often a bulk of the time that we spend, and CAD work, and then finally model preparation and model post-processing. So again, we've defined 2 types of staff members and 4 types of work that are done. That leads to 8 different effort fields, and each one of these effort fields is characterized by a number of hours and minutes or an unknown marker. All right, finally, Section 8 is a series of Likert style questions. These are all optional questions, but when available, this helps us to understand the impact the models had on end users. Section 9 also looks at the impact by virtue of more quantitative outcome measures such as surgical margin status. Mike and Priya talked about how to register for the registry. So in conclusion, I'll say this. So we are tracking towards go live for case submission later this month. Consider the data dictionary in these 9 different sections. keep in mind the idea of multiplicity of data fields which can be nested. Understand the distinction between anatomic models and anatomic guides. Look to the appendices to see the terms that are allowed to respond to the data fields. And really, again, the purpose of doing this is that this registry data will enable us to systematically evaluate our practice of clinical 3D printing. The registry project has been nothing if not a collaborative effort. There are many, many individuals who have put in a ton of work here. I would really like to acknowledge all of them. These are some references that I've used. And Nicole, I will turn it back to you now.
Thanks, Priya, Mike, and Dr. Wang. That was informative. Really appreciate you taking the time. We have some questions from the audience. The first I want to start with is, can a maxillofacial surgeon be part of RSNA? And the answer is yes, you can become a member. And I think it is an associate member if you're not a radiologist, but you're another type of physician. So you can become a member of RSNA. And then if you want to join the SIG, there's a small fee to be a part of that, but then you can be a part of the community. So we hope that you will join and encourage your colleagues to join as well and be a part of this group. So questions related to the registry. We have a question from Dr. Rabicki, and he asked to outline the actual steps to get onboarded. And we're planning to put more information on that out there. So that would be available. And I just want to ask Priya or Mike if you have anything else you can add to that for the actual steps.
We do have our whole support page, which kind of lists out information on how to register. And it does seem a bit cumbersome when you're looking at it, but once you're actually in NRDR and just clicking on corporate account registration and going through the steps, it does get a bit easier. It does walk you step by step through the application, but we're always available for assistance and to help you get registered and up and started.
Thanks, Priya. We had another question from Dr. Morris. Can all of the websites and email be added? Priya put some in the chat, so I hope that answers your questions or in the QA panel. We can also, when this recording is posted, we can try to post all the links there as well. So hope that helps. Another question is, how far back do we enter information? From July 2019 when the CPT codes went live, or only for future cases? So maybe Ken or Michael. Okay.
I'm happy to speak to that. I'd say really there's several answers to that. I think cases going back to July 1st, 2019 are of greatest interest. So if you have detailed information about models you created and how you created those models going back to July 119, then by all means, we'd be very interested in receiving that. But again, we recognize that that may not be the case for many users. It may be hard to remember how much time you spent creating a certain model, and in which case, perspective from now going forwards is good too.
And then to tag on to that, would historical data that may not have all the fields be desired? Like, what if I did a case, but I didn't remember all of the information that's being collected in the registry?
Yeah, I think that, that's still potentially useful, and one of the benefits of the registry is the analysis that it permits. And so if we're conducting an analysis that requires certain fields that were not specified, then we would be able to exclude certain cases. On the other hand, there might be types of analyses that don't depend on that kind of detailed information, in which case those retrospective cases might still be relevant. So, if in doubt, I'd say, submitting a retrospective case, it still has potential use.
Okay, great. Thank you. Thank you, Dr. White. Another question is, we are using Synopsys Simpleware, not any of the partners that you showed, Ken, I think, during the presentation. Does that mean that only users using Materialize can register for the registry?
I think I missed the first part of that. Can you repeat that?
there's a group that's using Synopsys Simpleware, and that wasn't one of the companies that's supporting the registries. Would they
Oh, I see. Yeah.
participate?
Yeah, thanks for asking that question. Even though we have those 4 sponsors that I listed, by no means does that draw any boundaries on the ability of participants to be part of the registry. If you look in the data dictionary, actually, you'll see that there are lengthy lists of different software applications for segmentation and for CAD that we list as options. And we also provide users with the ability to specify other packages not listed in the appendices. So no, the sponsors, the list of sponsors does not draw boundaries on who can participate.
Okay, thanks. We have a question. I did 5 cases of patient-specific implants that have all been detailed, but first case in 2018. Can this data be submitted?
Yeah, and I'm happy to take that one as well. And we recognize that people are doing amazing work with implants in particular. The reason that the registry is currently designed to receive information about anatomic models and anatomic guides only is because that mirrors the Category I CPT codes that went live last year. Those codes talk about anatomic models and anatomic guides. And so we're really kind of trying to provide supporting evidence around those codes, which is not to discount the work that goes into other things like implants. And I think that as time goes on, the registry may well expand to address other things like that. But for now, implants don't fit into the scheme of things that the registry will be accepting.
Thank you. What about just regular anatomic models or surgical guides that were made before July 1st when the CPT codes went live?
Yeah, so there is no time limit in terms of how far back people can go. And so retrospective cases going further back than July 1st, 2019 will also be able to be submitted, and again will serve to kind of broaden and fill out the picture of the work that people are doing. So there's no technical limit on how far back we can go.
Okay, thank you.
Also, Mike is indicating he's having audio trouble. I don't know if that's still true, but
yeah, you can't hear me, can you?
Oh, we can hear you now.
Oh. Okay, great. The only thing I was going to mention a couple of questions ago about the if you don't have all the information and you wanted to submit a case, I would encourage you to look at if you can, look at the dictionary to make sure you at least have all the fields that are listed as required. If you don't have those, then the case wouldn't go through. So that would be the only addition to what Ken had said. We can certainly take it without all the optional fields, but the mandatory fields would be necessary.
Thanks for clarifying that. That's really important to know. So we have a question from Dr. Moore. In Group 7, are all these people considered a qualified healthcare employee? And does the division between clinician and non-clinician have future monetary concerns?
Yeah, if I understand that question correctly, the purpose for making that distinction is based on the AMA and CMS definition of qualified healthcare provider, and so clinician is intended here to serve as a synonym for qualified healthcare professional. That is an individual who can independently bill for medical services.
Thanks, Dr. Wang. A couple more questions. Will there be an option to import multiple data sets such as a mass import, and can the registry facilitate interfaces that allow for automatic data input through .txt or XLS files?
That's another great question. Mike and Priya may have more thoughts about that. We have been interested in providing that since the inception of this project, and it is something that we have been actively talking about. When the initial go-live occurs, that will be through a graphical interface for data entry. But ACR, and again, I don't want to speak for the ACR staff, but there are near-dear mechanisms for receiving automated case submissions.
Yeah. That's correct. For the other registries, we do have that option, and Sajwan mentioned, up front, or the first launch for this registry, we would not have that, but we are working on making something like that available.
Great. Another question, are objects made from non-traditional imaging, such as 3D scanning, excluded from the registry at this time?
No, we actually, if you look in the data dictionary for imaging modality, there is a series of options for modality, which includes the traditional imaging modalities, but also includes other modalities, and scanning would be specified as a different modality.
Great. I think I'll do one last question before wrapping it up. How will data entered in the registry be monitored?
Yeah, that's another excellent question. Thanks for that one. So a few answers to that. There is a governance committee which is jointly appointed by RSNA and ACR, which will govern the monitoring and use of data. We do plan that for registry participants that they would receive routine, regular reporting on the data that they submitted. And that is how many of the other NRDR registries work. So if you're a participant in the DIR registry, you're familiar that periodically your institution receives a report that compares your institutional data with the aggregated registry data as a whole. And our vision is that for some basic metrics that participants in this registry would also receive something similar. So there's that reporting piece, and then also this governance committee, which will have oversight of data monitoring and use.
Okay, great. Thanks so much. So in conclusion, I want to thank everyone for attending. I also want to thank RSNA, the SIG members, and the SIG Leadership Committee for helping to put this webinar together. Finally, I want to extend a special thanks to our speakers for agreeing to be part of this webinar and educate us on this important topic on the 3D printing registry. Thank you, everybody, for attending.
Great. Thank you.